Well, thank you, Alan. And of course, as you just did that, my lighting went to hell. But okay,
Yes, it
anyway,
did. Yeah, well, I like that much better.
I think I'm, I think I'm back now. Okay, excuse me. Let me see where I am. Can you see my slide, my PowerPoint? Hmm.
Yes.
Al,
See, yeah.
okay,
No,
just
no, it's
just want
perfect.
just wanted to make sure. All right. Well, first of all, thank you for having me back. Good morning, all. Special good morning to my dear friend Olivia. Nice to have you there. I I'm looking forward to today's talk. This is going to be issues in cognition, audiology, and amplification. And we're going to cover a lot of bases. I would urge you to keep your phone out so you can take screenshots. I don't share my PowerPoints per se with audiences for a number of reasons that we won't get into. But I'm happy to have you take pictures as we go along because I think it's so important to really understand kind of what the peer-reviewed literature says and to be very clear as to, does hearing loss cause cognitive decline? The answer to that is no. Hearing loss in people who are at risk tends to exacerbate cognitive decline. Those two statements are both true, as best I know and as best the scientific community will weigh in, which I will share with you at least 40 or 50 peer-reviewed papers. So, buckle in, strap in. It's going to be exciting and fun. I said yesterday that I wanted to disclose um, that I am the Senior Director of Audiology at Essilor-Luxottica. This particular conversation will not have much to do with them at all, but I always like to disclose where I work and who pays me, because I think that's super important that when people are giving professional lectures, you know who's paying them, because, sometimes it could possibly influence what they say. Now, again, to be honest with you, and as honest as I can be, I've been working with Alan for 40 years, almost 35, 38, whatever it is. And I think, I always try to be unbiased. And when I do say something biased, I tell you that, I have a stake in that game, right? So I am the Senior Director of Audiology at Essilor-Luxottica North America, but this lecture has really nothing to do with them. So let's start with this. Kind of what I started with yesterday, a little bit different wording here. Science is a team sport. There's no one person who has his arms around all science and can tell you everything brilliant and correct at one time. It's a team sport and it changes over time. It's dynamic. As many of you know, I often start my lectures with hearing versus listening. And it's a very, very important discussion because hearing is just perceiving or detecting sound. As such, the vast majority of people with hearing loss, probably 80 or 85%, don't know they have hearing loss because they can hear. And this is such an important point because they will tell you, well, I can hear you fine. I don't think I have hearing loss. It's people are mumbling. It's all those other problems in the world. People don't pronounce words clearly. They don't enunciate. They speak too rapidly. They'll blame a bazillion things before they'll realize, oh, you mean I'm just hearing this little bit of low energy. Yeah, that's it. And you need to hear the high frequencies to make sense. So hearing is perceiving or detecting sound. Listening is making sense of sound. The demographics are very different than what you were taught. We covered a little bit of this yesterday. It's very much worth going over again. In the USA, if you go to the Global Burden of Disease Study from Ear and Hearing in 2024, you will see that there are 72.88 million people, USA, who have hearing loss. And so we're gonna speak the rest of the day about 73 million. Okay, so it's 72.88 million, but I hate saying that every time, so it'll be 73 million. In addition, you have the paper by Beck and Danhauer in 2019, peer-reviewed by the Journal of Otolaryngology ENT Research, where we said that you have 26 million people in the USA that have absolutely normal thresholds, but they have difficulty hearing, they have difficulty listening, and their primary complaint would be speech and noise. So that's 26 million plus 73 million, 99 million. So we'll call it 1 out of 3 people in the USA has hearing and or listening problems. And if we just talk about hearing loss by itself, it's 1 out of 5 people, 73 million. There's about 340 million in the USA. So there you go. Vision loss. You know what? Let me go back to hearing loss. When you think about hearing loss, you and I have learned 0 to 25 is normal. By the way, that's not correct. 0 to 15 is normal. That's what the data showed 100 years ago. And then if you go to ASHA, you'll actually see that 0 to 15 normal threshold, 16 to 25 slight hearing loss. Most of us don't use that term. We don't. And then 26 to 40 mild, 41 to 55 moderate, 56 to 70 moderately severe, 71 to 90 severe, and 91 plus profound. None of those are scientifically oriented categories. You won't, these are boxes that we put people in. We say normal, slight, mild, moderate, moderately severe, severe, profound. Those aren't scientifically derived. Those are categories of convenience. And so there's huge problems in describing hearing loss to people. And then you have the issue of pure tone averages, 3 frequency versus 4 frequency. I haven't really used a 3 frequency average in about 35 years. I've always thought you really have to represent, 3K or 4K, because those are the most important frequencies for understanding speech. The human ear canal has its maximal resonance at about 2,700 hertz, which means that you and I hear 2,700 hertz louder than most sounds. And so when you're using a 3 frequency average and you say somebody's pure tone average is 21, some people would say that's normal. I would say it's not. I would say that's a mild loss. But then you could have somebody with a 4 frequency average that's 21, and that's going to be a little bit flatter than necessarily a 3 frequency. So we have terrible names for these types and degrees of hearing loss. And then we get very poetic. And I've seen audiograms often from students, who will write a gently sloping mild to moderate sensory neural hearing loss going to profound. That we got to stop doing that. I just don't see the point. If we use 4 frequency pure tone averages and we describe the pure tone average, I think that's as close as we're going to get to a universal nomenclature. I'm not a fan of, there are people who think that we should use hearing numbers to describe hearing loss to make it super simple for patients. I disagree. I think we need 2 numbers. When we talk about blood pressure, it's systolic and diastolic. When we talk about vision, it's 20/20. We talk about hearing. If you just know your hearing number and it's 32, what does that mean? Does that mean you have, a mild loss, a mild high frequency loss? Does that mean that you have a precipitous loss after 4K, you have no hearing at all, 110 dB? And what's even worse than that is that when you have just a hearing number, it doesn't reflect your ability to listen. It doesn't tell you anything about your speech and noise score. It doesn't tell you anything about how you do in quiet versus noise. It doesn't tell you where you have difficulty in conversational speech. And if you have a hearing number of 8, that seems pretty darn normal. But if you have a hearing number of 8 and you happen to have auditory neuropathy, which many people above age 50 are going to have, we're not really, we're making it so simple that I think it's not really useful. I would really rather have in a hearing number 2 numbers, loudness and clarity. I don't know how to do that. I don't think anybody really knows how to do that, because we do have clarity numbers. We could look at an SNR 50, a signal to noise ratio, to get 50% of the words. We could look at a triple digit, test where we look at speech and noise, and you have to, there's lots of ways we could do it. But the only way it's going to happen is if AAA or ASHA or IHS or somebody assigns, a working group to come up with, the equivalent of 20/20 or 115 over 80. We need to develop that scale, and then people would be able to talk about their hearing loss in terms that make sense. Normal hearing makes no sense. And what else makes no sense is, oftentimes well-intentioned, good-meaning physicians will say, well, your hearing loss is normal for your age, which is totally a ridiculous statement. There's no such thing as normal hearing loss. That would be the equivalent of saying you have normal lower back pain, or you have normal diabetes, or you have normal migraines. None of that is useful, and none of that is correct. When somebody has diabetes, lower back pain, chronic headaches, migraines, they need to be diagnosed. And if they don't fit into a nice category, then they still need some sort of treatment. They still need some sort of guidance. And, we do this. I mean, it's a tradition in America. We blow off hearing loss. We take it as a joke. And that has to change. And again, I don't have any high hopes that this will change anytime soon. It's been that way for 75 years, since World War II, since we really started having a profession of audiology. So those are my primary thoughts on hearing loss and listening disorders and the demographics associated. But I do think that listening disorders is a huge issue because, when you think about the number one complaint all of us deal with every day, it is speech and noise. People cannot understand in crowded restaurants, cocktail parties, family gatherings. Given that speech and noise is the primary complaint, that's a listening disorder. That's not a hearing disorder. And, it gets characterized as hearing loss in some people. But again, you can have 26 million people in the USA with absolutely normal thresholds who have difficulty understanding speech and noise and will complain about hearing difficulty. And they would get on a hearing screening a pass, and they would get a hearing number score that was good. But there's 26 million Americans that will not reflect accurately what their auditory ability is. So, with all due respect, I think hearing numbers is a great idea, but I don't think it's a great idea to have one number. There's not one number that can encapsulate that any more than vision, any more than blood pressure, any more than miles per hour. Right? You have two things you're measuring there, and you can have a velocity number. Anyway, you get the idea. So that's hearing loss. Vision loss. I know nothing about vision. I will tell you a little bit about what I do know, which is that by the time you're 40 to 45, most people need vision correction. And that could be glasses, or that could be contacts, or a magnifying glass, whatever you want. And the thing is, vision loss and hearing loss often occur in the exact same populations, presbycusis and presbyopia. Many people who are age 50, the majority, I'm going to say, I'll go out on a limb and say the majority of people at age 50 have hearing loss. Why don't they know that? Why isn't it diagnosed? Well, because we have chosen to go from 250 to 8,000 hertz. Why do we do that? Well, because that reflects otolaryngologic diagnosis. Between 250 and 8,000, somebody has Meniere's disease, you can see a low frequency fluctuating hearing loss. When somebody has otosclerosis, you can see a Carhart notch. When somebody has noise-induced hearing loss, you can see a noise-induced loss. So we generally only measure that, but you should know that going back 100 years to the first audiometer, the first audiometer could measure up to 16,000 hertz. And what was that paper that I just wrote? Oh, that's the same Asher paper. Yeah. And so it's interesting to know that then that one didn't sell very well. Was it blanket on the name, but the second one they came out with was version 2, and that one only measured out to 8,000 hertz. So we've been able to measure up to 16,000 hertz for over 100 years, and we scaled it back to 250 to 8,000. So here's the problems with that, right? 250 hertz, it's middle C on a piano. The entire lower left side of a piano is not reflected in an audiogram. Everything above 8,000 hertz becomes negligible. You could lose 20,000, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9,000 hertz of hearing. Nobody's going to call it hearing loss until it hits 8,000, which is kind of random and not really scientifically solid. Some people will say, well, there's no speech information above 8,000. No, there's not much. There's not much, but there's an awful lot of acoustic information, which our brain uses for intraoral loudness differences, intraoral timing differences, head shadow effect, estimating distance by the timing and the loudness of sound between the two ears. So there's a lot of acoustic information above 8,000 hertz. And then finally on that, I have a new paper on extended high frequency hearing loss coming out. That's going to come out, I think, in January in Hearing Tracker. And we talk about the necessity of actually checking these frequencies, because a lot of people with extended high frequency loss will complain about tinnitus, will complain about speech and noise difficulty, will complain about hearing loss in general. And all of these things often will show up on extended high frequency audiometry. And the pushback I get on that as well, if hearing aids can't put out more than 10,000 hertz, what's the point? The point of diagnostics is not treatment. The point of diagnostics is to accurately reflect what's going on with the patient. Once we know that, then we deal with treatment. And the thing about treatment with hearing aids is we don't necessarily have to reflect the auditory deficit. In other words, think about tinnitus for a minute. Sometimes you'll have a patient with tinnitus at 10,000 hertz, and you could sometimes mask that with a babbling brook, or with pink noise or white noise or speech spectrum noise, or you could put in ocean waves, right? And the patient will say, oh, that's much better, I'm doing well. Or you might even just give them 5 to 10 dB amplification through the speech frequencies make the primary signal louder, and then they pay less attention to their tinnitus. So it doesn't have to be a one-to-one correlation that we have tinnitus at 15,000 hertz. But there's nothing we can do because hearing aids don't go out. That's wrong. There's a lot we can do, and there's not one solution. We have to try multiple solutions to get to the best solution for a particular patient. Okay, so vision loss. So vision loss, by the time you're 45 to 50, probably 99% of the population needs correction. If you have hearing loss untreated, and if you had vision loss untreated, from the studies by the Lancet in 2024, Dr. Livingston and colleagues' work, that hearing loss is about 8% of your PAF, population attributable factor. So let me go backwards. Your risk for cognitive decline, according to the Lancet 2017, 2020, and 2024, about 50% roughly of your risk for dementia is based on your DNA, deoxyribonucleic acids, and your age. Nothing you can do about those. But the other 50% of your risk for cognitive decline is due to 14 potentially modifiable risk factors, which we're going to cover in this course. But the important point right here is that auditory problems, right? Hearing loss undiagnosed, listening disorders undiagnosed, that's about 8% PAF, population attributable factor. And that does mean that 92% of your risk of cognitive decline has nothing to do with hearing loss. Just, sorry. But vision loss, they just identified in 2024 as a potentially modifiable risk factor, and that's like 2 to 3%. But there's literature, which I will share with you, that shows if you have both problems, hearing loss and vision loss uncorrected, your risk of cognitive decline goes up times 6. Yeah, so they're synergistic, right? 1 + 1 is 10. And I'll show you that in the peer-reviewed literature. So vision is very important when we're talking about communication disorders. The two primary senses, of course, are audition and vision. Now, neurocognitive disorders, I'll give you my brief overview on that. And if you want the details on any of these, go to douglaslbeck.com, go to, in the upper right is publications, go down to 2020 and scroll after that. There's about 40 papers I've written since then that give you the details and the exact references. So mild cognitive impairment is a stage between absolutely normal and healthy cognitive function and dementia. Most people do go through a stage of mild cognitive impairment, and people say, well, how long does it last? Well, it's different for everybody because we don't know when you're diagnosed, at what part of your problem did you get diagnosed. Many people with mild cognitive impairment, the majority will never be diagnosed. We just start to say, oh, that's mom. Oh, that's dad. He's a little forgetful. She's a little forgetful. He doesn't know where he put his keys. He doesn't know where his wallet is, blah, blah, blah. So maybe that's mild cognitive impairment. Maybe it's not. But mild cognitive impairment's not you misplaced your keys. That's just normal. If I give you this pen, can you see this pen? This is a really cool pen. This is an Oticon medical pen. I like their pens. So if I give you this pen and I say, hey, Alan, what's this called? And you're staring at it and you know what it is. You know what it is. Can't come up with it. And I say, it's a pen. And you, oh, right, of course it's a pen. It's not a pencil. That might be mild cognitive impairment. That's a terrible example, but you get the idea. And if I say, what do you do with it? And you can't come up with it. And I say, you use it for writing, right? And drawing. And then the patient immediately recovers and they got it. So that might be mild cognitive impairment at a very basic level. But it's memory function, it's executive function that they're a little bit impaired, but not demented. So mild cognitive impairment, what's the epidemiologic incidence of that? Well, according to the Journal of the American Medical Association in 2022, the incidence of mild cognitive impairment, once you're age 65 and older, and Alan and I are both over 65, is 22%. So 22% of the population, 1 out of 5 people over age 65 has mild cognitive impairment. And 1 out of 5 of those converts every year to dementia. So those are the numbers on MCI that you should be familiar with. Dementia and neurocognitive disorders. Of course, the single most common neurocognitive disorder is Alzheimer's. Alzheimer's is roughly 2/3 of all neurocognitive disorders. Alzheimer's takes about 20 to 30 years to manifest from the first microcellular changes. Right now, on May 19th of 2025, was it the world? No. It was the FDA announced there was a new blood test for Alzheimer's. If you're not aware of this, look it up. May 19th, 2025. And it is a blood test that looks at amyloid plaque versus tau proteins, which are the two most common byproducts that we have in our brains when we have Alzheimer's and other forms of dementia. And we used to think that if we could just knock down the amyloid plaques, maybe things would get normal. And we do have drugs that can do that, different drugs that are FDA approved that can really reduce, effectively amyloid plaques and tau proteins, but it doesn't bring back anybody's memories. And it really hasn't slowed the progress of dementia substantially. It slows it down a bit, and that's nice. But none of the drugs that are out there, I'm not going to even try to say the names, but there's two or three that the FDA has approved in the last few years, and they do work to reduce amyloid plaques. But do they change the trajectory of the patient? They do a little bit, not substantially. And so, when I say substantially, right? I mean, if it's your mom, your dad, your spouse, your whoever, yeah, it could be substantial for that individual. I don't mean to say it's not substantial for everybody, but I mean, statistically, it doesn't change the course in a dramatic way. But this new blood test looks at the percentages or the ratio between amyloid and tau, and it's accurate in saying that you have or don't have Alzheimer's with about 95% certainty. So that's a really good thing to know because, prior to May 19th, 2025, Alzheimer's was a disease, of exclusion, right? Or you have signs like Meniere's. I mean, there's not a real lab test for Meniere's. You could just say an ECOG is, but no, you could have a normal ECOG and still have Meniere's, which is unfortunate because, it's like the reason we do Meniere's is to show that we have SP-AP ratios that are consistent with Meniere's, but it doesn't really necessarily diagnose Meniere's disease. Anyway, so this is the thing. Now we do have a blood test that's quite accurate in diagnosing Alzheimer's. So Alzheimer's is about 2/3 of all dementias. And another thing you should know about Alzheimer's, by the time you reach the age 80 to 85, in the USA, about 1/3 of all people have Alzheimer's. So, and people think, oh, it's increasing its common presentations. More and more people all the time, are getting Alzheimer's. Well, the issue is that we're living longer. And, so you have to understand, in 1800, the average age of death in America was 37. In 1900, the average age of death was 55. Now it's like 78 to 80. And so when you get to that very old octogenarian age of 80 to 85, your chance of having Alzheimer's is 1/3. You didn't see much Alzheimer's when people died at 55 because it takes, age 80 for most of it to manifest. And of course, there's some people who are going to have it in their 40s and 50s. Of course there are, because, these are general trends when we report these numbers. These are epidemiologic factors which don't represent the patient in front of you. They represent the population. And this is where people get in trouble. They take things out of context and try to apply it to their patient, and that doesn't work so well. So the most important things to know about neurocognitive disorders are the numbers we've just covered, and the fact that of the other 1/3 of neurocognitive disorders, you have things like Lewy body disorders. That's what Robin Williams had. You have Parkinson's with dementia. You have vascular dementias. You have all sorts of other dementias. But the big thing to know is, of course, Alzheimer's. So let's move on. So my friend, and unfortunately Patty died about, I don't know, 7 or 8 years ago. Dr. Patricia Krikos wrote in 2006, so let's call that 20 years ago, Audiologic Management of Older Folks with Hearing Loss and Compromised Cognitive and Psychoacoustic Auditory Processing Capabilities. And this is peer-reviewed. And she said, with regard to hearing, simply testing their peripheral hearing is not sufficient. And she was right then. And she said that for older listeners, performance on auditory processing, and I want you to understand this when she says auditory processing, my understanding is she means central auditory processing disorders, subclinical hearing loss, suprathreshold hearing disorders. In other words, anything that is not captured on a normal airborne and speech test, right? Functional difficulties making sense out of sound. So for older listeners, performance on listening tasks was more related to differences in their cognitive function rather than auditory function. And, that's pretty revealing, right? Because When people have difficulty understanding speech and noise, when they have difficulty listening, assigning meaning to sound, it's more related to their cognitive function than their auditory function. And that's kind of a kick in the butt for most of us because we deal with patients every day who come in and they can't understand speech and noise. And Patty said 20 years ago that's more a cognitive thing than a auditory thing. Okay, big deal. A good thing to underscore is always correlation versus causation. And I wrote a couple of papers on this, which I'll share with you in a minute. Correlation is the most common reason that you wear a seatbelt and you have an airbag. Driving a car does not cause head injury. Driving a car in an accident, being unrestrained, causes head injuries, right? And of course, there are variations on each of those. I'm not saying it's black and white, but the reason that you wear a seatbelt and have an airbag and you have, safety mechanisms built in throughout the car so you can survive a crash is because of the correlation between car crashes and head injury. It's not causation. The reason that we all think cigarette smoking is terrible, it's awful, you should never do it, is correlation between cigarette smoking and emphysema, cigarette smoking and lung cancer, which is about 20-25% of people who smoke get lung cancer. And that's people thought it was 1-to-1. It's not. I mean, I looked it up before writing this paper, and I quoted 2 or 3 sources that say about 1 out of 4, 1 out of 5 people who smoke get lung cancer. So smoking does not definitively cause lung cancer, although I wouldn't take the risk myself. So and in many different areas of medicine, high blood pressure. Why don't you want high blood pressure? Because it might cause a stroke or a heart attack. Correlation. Does that mean that having high blood pressure will cause? No, but there's a very high correlation. So my point is that in medicine and in healthcare, we're driven by correlations. If we get a causation, that's great. Then we know definitively avoid that situation, right? Avoid the landmine. But there's not much in medicine that's direct causation. That's my opinion. You could say bacterial infection. Well, even like when you think about meningitis, right? A bacterial meningitis, or it's not 1-to-1 that if you have A or B, that's going to cause C, but it pretty much might, and then you have to do what you can to avoid that outcome. So correlation is, I think, the essence of our cautions and our warnings and why we do what we do. When you think about when you go for your Welcome to Medicare exam and you sit down with some technician or a physician, you go through, is your house safe, right? Do you have throw rugs that might slip and slide? Throw rug doesn't mean you're going to fall. Throw rug means you have a higher likelihood of falling. That's correlation. Do you have rails in your shower to grab onto? If you don't have rails, that means you're going to fall. No. If you don't have rails, that means you have a higher likelihood of falling if you went to catch yourself and you couldn't. So you get the idea. Most of our safety precautions and activities, are based on correlation, not causation. So this is an article that I wrote with 25 of my best friends. And we published this in Hearing Tracker. The reason we did that is we wanted to get it out there quickly because there were many people in audiology across the world saying, oh, you shouldn't talk about hearing loss and cognition because that's just correlational. Yeah, like smoking, like driving, like falling. Yeah, but we talk about falls all the time in audiology, don't we? And there's no, the fact that you have Meniere's doesn't mean you're going to fall. It means there's a high correlation with it, or lymphatic eye drops, or dizziness. So I thought this through one day, and I was thinking, yeah, we got to come out with something on correlation versus causation because we had people saying that correlation is not good enough to have a discussion with a patient, and I think it's more than good enough. And so do these 25 co-authors. I think there's more like 30 co-authors, but multiple correlational meta-analysis and longitudinal peer-reviewed reports have demonstrated that untreated hearing loss tends to exacerbate cognitive decline in at-risk people. Who said that? Well, I don't know. Everybody. The Lancet has said that, of course, in multiple studies. The Achieve study has said that. The studies out of New Zealand have said that. The Amiva study out of Bordeaux, France said that. And to ignore that, I think is folly. I think because there's such a correlation in at-risk people, we should be very comfortable being familiar with that knowledge and using it to the patient's advantage, not using it as a scare tactic ever. And if you do that, frankly, I'd be happy to, to tell you that I don't think you're practicing ethically or morally. I mean, you, the fact I was at a lecture that I did, I don't know, 6 months ago, and I won't tell you where or who it was for, but it was a group that wanted me to say hearing loss causes cognitive decline. And I'm thinking, dude, didn't you read any of my papers? Because I say hearing loss does not, unless you're in an at-risk group. And they were saying, yeah, but what if you have a 26-year-old with a high frequency loss? And I would say, well, the at-risk criteria from the Hopkins study, the Achieve study, you have greater incidence of greater degree of hearing loss. You're an older person. You have a lower socioeconomic group. You have lesser education. You have multiple comorbidities, let's say cardiovascular disease, atherosclerosis, diabetes. You're a polypharmacy patient, more than 5 meds you're taking. Those are the people who are at risk. So untreated hearing loss in that population tends to exacerbate cognitive decline, which is exactly what we said here in March. I think this was, February 2025. And so that's my belief. And I think all the people who co-wrote this with me believe this as well. And so I don't think it's a stretch to say that what's really important is not the idea that we should stay in our lane and not to, we talk about things like anxiety and depression and social isolation, all from untreated hearing loss. Those aren't particularly our areas of expertise, but we do talk to patients about that because we know how important it is that people have normal perceptions of hearing and the ability to listen so they can feed their brain a better signal and make more sense out of the world. And we'll talk about that as we move on. But get a copy of this paper. This paper is the essence of today's lecture. Excuse me 1 second, because I think I'm going to cough, and I don't want to cough in your ear. Maybe I'm not going to cough. Okay, maybe not. Relationship between speech and noise threshold, hearing loss, and cognition from age 40 to 69. So these are kids, compared to me and Alan. Excuse me, I'm so sorry. And this paper was published by my pal, Dave Moore, Edmondson Jones. I'm sorry, I don't know Pierce Dawes. I do know Pierce is an old pal of mine. I took his place on the SIG, it was a group out of the UK, special interest group, and Kevin Monroe. But they published this in 2014, so let's call it 10 years ago. And here's what they said about the relationship between speech and noise and cognition. Moore et al., these guys, said that older adults' declining cognitive processing ability is associated with a reduced ability to understand speech and noise. And importantly, they said for middle-aged people, again, age 40 to 69, with poor speech and noise, their speech and noise difficulty could be a first warning of a need for intervention. Most of us didn't take that very seriously, but they were very wise to notice that 10 years ago. Now, what happened after that is in 2022, Dr. Stevenson and colleagues in the UK Biobank study of 82,000 people, 82,000 people, that's a lot of people. They were 60 plus years of age and they were observed for 10 years. And it was the UK Biobank cohort. If you haven't looked that up, you should. It's kind of like the Framingham study. It's been going on forever. And we get a lot of excellent epidemiologic, medical, healthcare information from these very, very long-term studies. People with bad speech and noise scores had an increased risk of developing dementia compared to those with normal speech and noise ability. Wow. How come we don't know that? Well, because most of us don't do best practices. Only about 1 in 5 of us do. And best practices by AAA, ASHA, or IHS, they all say you should be doing speech and noise. And in clinical audiology and hearing aid dispensing, most people do this. They say, well, I do it when I need to do it. And honestly, you don't know when you need to do it. I've written a lot on speech and noise tests, and you can read the summary of that in 2019. Dr. Benitez and I wrote a speech and noise test that's free, costs you nothing, and published by AAA. And there's nothing to buy. It's a protocol. It's how to do a speech and noise test within 1 dB of accuracy. It takes about 2 minutes. Excuse me. And most people have never heard of that either. So I would urge you to do that, because if you have a patient with absolutely normal thresholds and they have no complaints about speech and noise, I would still do the test because it's best practices. And you don't, you can't tell by having a conversation with the patient or by looking at their audiogram who has speech and noise difficulty. But Rich Wilson wrote this brilliant paper of over 3,000 veterans, and he said about 85% of them had absolutely normal thresholds, but only about 10% of those had normal speech and noise. I think that's coming up in this deck, but we'll see. Anyway, so back to the biobank study, the hazard ratio for dementia. So what's a hazard ratio? A hazard ratio is like a fraction or a percentage or a decimal point, but it's over time. So if I say, the incidence of falling down and hitting your head is 50%, that means 50% of the time when you fall down, you're going to hit your head. But if I say the hazard ratio of that is 50% over 10 years, that means people who fall down over 10 years, so you have to add that time factor in there. So here's what they said. They said over the 10 years, the hazard ratio for dementia for people with speech and noise was 61%. So if you had a bad speech and noise score and we watched you for 10 years, your hazard ratio goes up to 61%. Does that mean everybody with bad speech and noise is going to develop dementia? Nope. Doesn't mean that at all. It means the majority of people in their study who are over age 60, who started as dementia free, who had a bad speech and noise score, 10 years later, 61% of those had some sort of dementia going on. The authors report speech and noise hearing impairment is independently associated with incident dementia. So take a picture of this. It's a pretty interesting study. And, it's 82,000 people over 10 years. And they're saying, yeah, the people who had bad speech and noise had a much higher incidence 10 years later of cognitive decline. And you can't just do speech and noise and say that that's a surrogate for cognitive screening or vice versa. These two are independent tests and they mean different things. And you can't look at somebody's speech and noise score and say that they're at risk for cognitive decline without doing both tests. You need a speech and noise test and probably a cognitive screening. And to do half of it, you could get by and do half. I guess if the patient had a poor speech and noise score and relatively normal thresholds, and they were not doing good on communication and listening assessment tests like the IOI or the AFAB or the SCAN or whatever you're doing, then you could refer, but very few people are going to know what to do with that. Say, oh, they had a bad speech and noise, so I want to do a cognitive screening. I would urge do a cognitive screening yourself. It ain't rocket science. It's pretty straightforward. There's many of them available. Most of them are free. But the thing is that you don't want to do a cognitive screening unless you've been trained to do it because it's easy to make a mistake. Dr. Amoeba study, this is the classic from 10 years ago. So she and her colleagues in Bordeaux, France, self-reported hearing loss, hearing aids, and cognitive decline in older folks, 25-year study, peer-reviewed, Journal of the American Geriatric Society. So they said hearing loss was assessed via questionnaire. It was self-perceived hearing loss. There were no hearing tests in the study, but it was 3,670 people. About a third of them, 1,276, reported hearing loss, and 2/3 said no hearing loss. Cognitive decline was measured using the mini mental state exam, and they did that over a 25-year period. Self-reported hearing loss was significantly associated with a lower baseline cognitive screening via the mini mental state exam and greater decline during the 25-year follow-up period. So pretty significant. People with hearing loss who had no hearing aids, they had faster and more significant decline in their mini mental state exam. People who had hearing loss and wore hearing aids, no difference in their cognitive decline from the 2,400 who said they had no hearing loss. Conclusion, self-reported hearing loss is associated with accelerated cognitive decline in older adults. Hearing aid use attenuates such decline. Pretty straightforward, right? People who reported that they had hearing loss did not do as well on their cognitive screening, and they declined more rapidly than people without hearing loss. Based on how many people? 3,600. Okay, we talked earlier about the potentially modifiable risk factors for cognitive decline. So I like to use this 2021 because I think this is the one when most audiologists, hearing aid dispensers, et cetera, were talking about cognitive decline. And so Dr. Livingston and colleagues said there were 12 potentially modifiable risk factors at that point. less education, hearing impairment, obesity, physical inactivity, low social contact, alcohol consumption, hypertension, smoking, depression, diabetes, air pollution, and traumatic brain injury. They also report higher childhood education reduces the risk of dementia. And I'll tell you, in all the dementia studies I've read, which is, a couple of hundred at this point, having better education does seem to be a good protection against cognitive decline. It doesn't guarantee anything, but people with higher education, people who are continual adult learners, people who continue to learn, people who continue to have curiosity and seek solutions, generally have more cognitive reserve. That was a study that goes back to the 80s. And it was, I can't remember the fellow's name at the moment who did the study, but it was called the NUN, N-U-N, NUN study, done in the 80s or maybe the late 70s. And it was a study of hundreds of nuns who were older, in their 80s and 90s. And this particular researcher noticed that older nuns seemed to have less cognitive decline than the regular person who's not a nun. And so he got permission to study nuns' brains, after they had passed. And what he found is that nuns had the exact same amount of amyloid plaque and Alzheimer's, we call it diabetes type 3, Alzheimer's, decay, and terrible things that went on with their brains, but they didn't show the signs or symptoms of Alzheimer's. And he developed this theory called cognitive reserve, which means that the more pathways, the more well-developed your neuronal pathways are, the more access you have to those original memories and those ideas and concepts. So by being a lifelong learner like a nun, because think about nuns, what do? They teach all day, they pray all day, they work in groups, they support each other socially. They're generally not smoking and drinking, and they do healthy things. They plant gardens, they take care of people, they do wonderful, helpful things. They are not socially isolated. They're working in groups. So those behaviors, which if you think about it, that's kind of the blue zone thing, right? The people who live in blue zones versus red zones. That was another book from the, I guess, 80s and 90s as well, that talk about people's lifestyle tends to give them better outcomes with regard to their cognitive function. So anyway, these are not shocking at this point, but it was interesting to see them all accumulated in this one paper, which was the second in the series on cognitive decline. But then in 2024, the excuse me, the Lancet Standing Commission added 2 potentially modifiable risk factors for dementia: vision loss and high cholesterol. And that makes good sense to me. High cholesterol and triglycerides and atherosclerosis and anything that gums up the works, of your vascular system, probably not going to be good for you. And vision loss, so that was interesting because I guess it was 2022 or 2023, I published a interview I did with a neurologist, Dr. James Galvin, and it was a 2-part interview. And Dr. Galvin was saying, because I asked him about the 2020 Lancet Commission, and I said, what do you think of these potentially modifiable risk factors? And he said, I think they're all true. He said, I'm sort of surprised that they limited it to 12, because he said they didn't even mention vision loss, and to him, it was already an issue. So I'm not trying to slam the Lancet Commission. They did a brilliant job, but the neurologists have been aware of this for a long time. So these are the original 12 plus the other 2, vision loss and high cholesterol. So that's why we have 14 now, right? And the potential for prevention is high, and overall nearly half of dementias could theoretically be prevented by eliminating these 14 risk factors from your daily life. I did an interview with Dr. Young Trin. He is a MD in Southern California. He probably has the largest Alzheimer's clinic there. And he and I did an interview together, and he was talking about that he anticipates that as time moves on, probably 60, 70%, 75, 80% of all cognitive decline will eventually be attributed to potentially modifiable risk factors. And I think he's right. I think he's totally right. The evidence that treating hearing loss decreases the risk of dementia is now stronger than when our previous commission, 2020 commission, was published. So this is not like somebody selling hearing aids. This is not somebody trying to scare people into buying hearing aids or any such thing. This is the Lancet Commission in 2024 saying the evidence that treating hearing loss decreases the risk of dementia is now stronger than when our previous commission was published. But it's only in people at risk. It's not everybody. If I have a PhD in electrical engineering. And this young woman comes to see me with her PhD in electrical engineering, and she has a bilateral mild to moderate sensory neural high frequency loss. Am I worried about her in dementia? No, not unless she shows any of the risk signs. I'm really not. Could she develop dementia 30, 40, 50 years later? Yep. But by then she'll also have some risk signs that would indicate that we need to be concerned about it. None of this stuff happens overnight. And maybe one day somebody will have a paper that'll come out and say, people in their 20s with precipitous ski slope losses, 50 years later, have much, much higher incidence of cognitive decline. But we don't know that now. And to say that and to threaten people and scare people is crazy. It doesn't make any sense. And again, I would argue it's immoral and unethical because we don't have any data to show that a 28-year-old PhD who's extraordinarily brilliant, that we have to worry about it until they start having other, at-risk signs and symptoms. Oh, but shouldn't we just protect everybody? Yeah, and we should all walk around in rubber suits so that we can't fall and we can't trip down the stairs. And it gets a little bit crazy. I think when we have good epidemiologic indications that X correlates with Y, we should be cautious about it. If you want to live in a bubble and never go outside, because if you go outside, you might be exposed to fungal infections and viral infections and bacterial infections. Yeah, you might stay inside, never go out. And when you go out, wear your bubble. It's ludicrous. It really is. At this point, science changes it, but right now I don't see it. Use of hearing aids appears to be particularly effective in people with hearing loss and additional risk factors for dementia. Right out of 2024 Lancet. Take a picture of this, very important, and we're going to move on. Now, why would sensory deficits even cause cognitive decline, right? Or cognitive issues? Well, there are many hypotheses. The Harbinger hypothesis talks about, if you have untreated hearing or visual loss, so you have untreated sensory impairments, that may lower your performance on cognitive assessments, because when somebody's saying, hey, I want you to remember these things, three-legged stool, elephant, and lozenges. I want you to remember that for 10 minutes. And you don't hear them well. And you didn't really hear those to begin with. How are you going to remember them 10 minutes later? The person being assessed may not hear the question or statement completely or properly, and the assessing person may not have clear enough vision to provide redundant acoustic information. So when somebody doesn't hear or see properly, or within normal limits, then their ability to retrieve the information may be quite a bit less. So that's the Harbinger hypothesis. Cognitive load, you've all been hearing about, and we've had a lot of great things on the AuD Institute about this. Cognitive load hypothesis posits that degraded sensory input, such as impaired auditory or visual signals, places a greater burden on cognitive resources, right, such as working memory, attention, and executive function to interpret poor quality sensory information. So this, I think, is very well known to this audience, to audiologists, to dispensers, to ENTs and stuff, because it makes good sense. When you have to spend a lot of time processing information, you have to use other parts of your brain, which otherwise we're going to auditorily process that information. But when you have to impose on other parts of your brain to do that processing, you have a limited capacity there. Here's another one, the cascade hypothesis, which suggests sensory loss leads to decreased social engagement. I wrote a paper on that about a year ago. Reduced participation in cognitively stimulating activities, and diminishes awareness of the external environment. So you have hearing loss, you have visual loss, and your life gets smaller. You engage less and you converse less, and your brain does not do well with sensory deprivation. Common cause hypothesis. This is one that I've advocated a lot the last 10 or 15 years. Carol Flexer and I wrote a paper on this in 2011. Not this in particular, but we referred to this. The paper was Listening is Where Hearing Meets Brain. We wrote that in 2011. Listening is where hearing meets brain. And what we said is that supposing that you have hearing loss and you have cognitive decline, why would that, how could those two be similar or be related? And it's the idea that if you have atherosclerosis, cholesterol, triglycerides gumming up the internal diameter of your blood vessels, that decrease in perfusion could go to your middle cerebral artery, your anterior inferior cerebellar artery, your posterior, and all of and the circle of Willis in general. So your perfusion throughout your brain would be decreased because of goo in your blood vessels. And one of those major vessels would be connected to the labyrinthine artery, which supplies nutrients and blood and oxygen and more to your inner ear. So you could have hearing loss, you could have vestibular imbalance and disorders because of low perfusion to the inner ear. So that would be the common cause hypothesis, that your cognitive decline or your mild cognitive impairment and your inability to hear or to balance well could both be due to lower perfusion of blood through your ear and your brain. So that's common cause. And then there's this really cool new one called the cognitive maladaptation hypothesis, which argues that prolonged sensory deprivation, eyes and ears, especially during the early stages of hearing and vision degradation, may trigger maladaptive neuroplastic changes in the brain. These changes involve the brain recalibrating to the distorted or degraded sensory input, which reinforces cognitive distortions. Confusion may contribute to cognitive decline. Where'd this come from? Well, so I was at a bar with Keith Darrow in Scottsdale, Arizona. I think I told you the story yesterday, but everybody wasn't there. And I had this idea about cognitive maladaptation. So I brought it to Dr. Darrow because he's an audiologist and a neuroscientist from Harvard. And I said, Keith, what do you think about this? And he had some really good insight and helped me focus this idea. So he and I wrote it up. And then we brought it to Dr. Trin, who treats more Alzheimer's patients than probably anybody. And he added some color to it and made it better. And then we thought, well, something's still missing before we send this out. Let's ask who's a genius, who's super smart on this stuff. Oh, Hannah Glick. So we asked Dr. Glick to read it, and she basically rewrote the whole darn paper. So Keith and I talked, and I said, we got to make Hannah the first author. This cannot be Beck and Darrow. This is going to be Glick, Beck, Darrow, and Trin. So that's what it is, and that's where it came from, and that's the cognitive maladaptation hypothesis. So in a nutshell, it's this idea that your brain is neuroplastic, neuroplasticity is going on from birth to death. And when you have degraded visual input, degraded hearing input, your vision and hearing are distorted, attenuated, incorrect, not representative of the entire acoustic or visual scene. And so your brain tends to recalibrate to that over time. It's a hypothesis. Maybe I'm wrong. Maybe we're wrong. I don't think so, though. I think it's going to prove to be a primary hypothesis with regard to how sensory deprivation and sensory attenuation impacts cognitive decline over years or decades. This is what the paper looks like. It's peer-reviewed and came out. Let me see if I can find the date. Oh, here it is. April 23rd, we submitted it, and a few weeks later, it got published. We were like thrilled with that because that's a really super fast turnaround time. The article reviews several established hypotheses explaining the possible relationship between hearing loss and cognitive decline, while suggesting a similar process may occur in other systems like vision. Building on these existing frameworks, the article introduces an alternative perspective, the cognitive maladaptation hypotheses. So you get the idea. If you don't have a copy of this, it's open access. You can simply Google cognitive maladaptation hypothesis and put in Glick and Beck, and it should pull up on Google. All right, let's move on. Okay, so we're talking, we talk a lot, obviously, as audiologists and hearing aid dispensers, we talk a lot about the interaction between audition and cognition. But it also occurs in vision when you have maladaptive sensory input through your vision system. This is a study of 300,000 people who had cataracts, and they had cataract surgery. So cataracts are associated with the risk of cognitive impairment and dementia. I mean, pretty impressive, right? Alzheimer's disease and vascular dementia. Cataract surgery reduces the risk of dementia by 50%, 50%. Kind of interesting to me because we're kind of new to this in audiology. I mean, the first time we did a major thing that I'm aware of was our 2015 AAA roundtable discussion in San Antonio, which again, as I mentioned yesterday, was set up for 200 people, but we had 400 people in the room and it was standing room only. So, we're new to this, but this has been going on. This knowledge has been in optometry for a long time. This is a study from 2022, association between cataract extraction and development of dementia. And this is Journal of American Medical Association. And they said removing cataracts may reduce the risk of dementia by 29% based on 3,000 adults with cataracts or glaucoma. And my colleague and dear friend, Dr. Vicky Zarinko, is an optometrist. And she would say that one of the major contributing factors is people not wearing glasses when they should, or not wearing contacts when they should. Those are referred to as refraction errors, when the eyeglass or the lens of some sort is not refracting light appropriately onto the retina so that one can make sense of the world. And she says the largest contributing factor to that may well be refraction errors, which is, for want of a pair of glasses, people may suffer cognitive decline. Speaking of Dr. Zarinko, this is a brand new paper that will be released next week, Dual Sensory Impairment Update 2025. And we talk about dual sensory impairment is the concurrent impairment of hearing and vision. DSI is linked to increased risk of depression, loneliness, anxiety, social isolation, accelerated cognitive impairment, cognitive decline, and dementia. Does that sound familiar? Yeah, that's what we've been saying about audiology, for 10 or 12 years now. Of course, the fear of dementia is huge. However, fear of a particular disease may actually prevent people from seeking a diagnosis. In general, cancer, which is 34%, and dementia, 29%, are the two most feared diseases. But for people 65 plus years, dementia is the most feared. Therefore, preventing or delaying dementia is extremely important, and it's highly correlated with early and effective treatment of vision and hearing problems. Unfortunately, these correlations are not well known or recognized by professionals or the public. So this paper has not been released. It'll come out on Monday. You should be able to just really just put this into Google and get it on Monday. Dual sensory impairment, update 2025, Beck and Zarinko. Okay, so that paper's coming out, and half of it you'll be familiar with because I reviewed the audiology literature, and Dr. Zarinko reviewed the optometric data, and then we put those two things together. It's coming out Monday. We're actually presenting a paper on this in Boston early next week. Oh, you know what? It's not coming out Monday. It's a week from Monday. It's October 13th. I have to learn to use a calendar one day. All right. We are at our halfway point here. It is 9:56 in the mountain zone, which is where I am at the moment. So let's take a 4-minute bio break, okay? And I don't think Alan would mind, but I will see you back here in 4 minutes, and then we'll do the second half of this because it's a 2-hour course. So I'm gonna get a drink of water. I'll see you back here in 4 minutes. All right, we're good to go. Let me just check this chat thing. I think we're good there. Okay. And we're gonna get out of that. And so, part 2. Thank you for allowing me a drink of water. I needed to cough like a maniac and have some orange juice. All right, association between hearing aid use and mortality. Remember how I said earlier that epidemiologic studies represent a group? They're not necessarily true for your patient. And I think that's true, and I think it's important to be aware of it. So sometimes studies get written and published that are totally true, but there might be an underlying thing that's not disclosed or noticed. So this study came out, and I love this study, a mortality follow-up study, people wearing hearing aids. Came out, a year and a half ago, something like that, January of 24. 10,000 people, National Health and Nutrition Exam Survey, 1999 to 2012. So, it's a respectable, group they're looking at. 1,800 had hearing loss, half male, half female, regular hearing aid use, with hearing loss was 12%, which is, kind of the numbers I shared with you yesterday. Larry Humes would say that about 80 to 85% of people who have a need for hearing improvement, only about, 15% of them do it. And that's pretty much what this study says. Hearing loss was an independent risk factor associated with higher mortality. People who have hearing loss, you know, without treatment, die sooner. People with hearing aids die later. There's no difference in mortality in non-regular hearing aid users and never users. Regular hearing aid use was associated with a lower risk of mortality than in never users in US. So I kept waiting for some hearing aid store to say wearing hearing aids increases the length of your life or something like that, which is kind of silly. It doesn't mean that the study is wrong. I think the study is right. But the thing is that the reason that I would presume that these people who wore hearing aids had a longer life is the people who wore hearing aids are clearly in the minority, right? 15% of people with hearing loss. And they are seeking solutions. They want to hear better. They want to communicate better. They're trying to take better care of their health. They're trying to interact with other people, so they get hearing aids. So that's a selection bias, right? So when we talk about people wearing hearing aids living longer, well, it may be because they were seeking a better quality of life to begin with. It wasn't their hearing aids, but they're actively involved in the quality of their life and trying to live a healthier and longer life. So they do what their doctors tell them. They do what their audiologist or their dispenser tells them to do when they have significant hearing loss and blah, blah, blah. So I'm not saying the study's wrong, but I'm saying that to me, what is apparent here is that they help seeking behavior of the 15% of people with hearing loss. That's probably why they lived longer. I don't think it had anything really much to do with the hearing aid in particular. So that's just my view of the world. Adult onset hearing loss and incident cognitive impairment and dementia, a systematic review and meta-analysis of cohort studies. This is in Aging Research Reviews 2024. And look who's here, Gil Livingston. He's the guy that wrote, that was the premier author of all those Lancet studies. Frank Lynn is on here. Frank's an old friend of mine. He and I did a really good podcast together called This Is Your Brain on Hearing. If you haven't heard it, I would recommend it. It's great. It's a lot of fun. It's about a 30-minute. We did it about a year ago. Two neurologists in Southern California run This Is Your Brain On, and this is Your Brain on Hearing. So they had Frank Lynn and me on that. It was a ton of fun. Really good podcast. So anyway, these guys summarize the evidence on adult onset hearing loss as a risk factor for incident cognitive impairment. And by the way, they looked at 1.5 million people. Stop, hold the presses right there. If you have a bigger study showing that hearing loss in at-risk people doesn't impact their cognitive decline, please bring that forward. This is 50 studies, 1.5 million people. Hearing loss was associated with incident dementia risk, mild cognitive impairment, Alzheimer's disease dementia, but interestingly, not with vascular dementia. I don't know why that is. Nobody knows why that is. But this is so interesting. They came up with a formula after 1.5 million people. For every 10 dB of hearing loss, there was a 16% increase in dementia risk in people who were at risk, not in everybody with hearing loss. Again, I'm going to go back to what I said about 100,000 times already in the last 10 years. Hearing loss does not cause dementia. Hearing loss in at-risk people tends to exacerbate cognitive decline. Conclusion: adult onset hearing loss increases the risk of incident cognitive decline, dementia, and mild cognitive impairment based on 1.5 million people, 50 studies. This one just came out about 2 months ago. The impact of short-term hearing aid use on cognitive performance, noise acceptance, and self-perceived benefit. This was in the American Journal of Audiology. As you probably know, that's an ASHA publication. Small study compared to 1.5 million people, 29 adults, older, 41 to 84, average age 70, bilateral sensorineural hearing loss. Repeated measures were done to explore the changes in cognitive performance, self-reported hearing difficulties, noise acceptance at baseline 2 and 4 months after receiving their first pair of bilateral hearing aids. And what they found, this is pretty impressive. a significant average improvement after 2 and 4 months of hearing aid use. I mean, this harkens back to me to the Glick and Sharma study that came out, what was it, 7 years ago, showing, that people who were appropriately fitted with hearing aids, after 6 months, right, their brain changed. And they were able to go back to a healthier auditory status. And we think that was because the hearing aids provided a much better auditory signal and more information to the brain. And these guys, who I don't think, I would have noticed if they'd referenced Glick and Sharma. I don't think they did. I could be wrong. But independently, they found sort of the same thing, a significant average improvement in cognitive performance and self-reported hearing difficulties after 2 and 4 months of hearing aid use. Significant average improvement on working memory tasks in a low cognition group drove the overall significant improvement. So what this means is the people who did worse, generally speaking, had lower cognitive ability. They improved in their fluid cognition and significant average improvements in cognitive performance, self-reported hearing difficulties, and noise acceptance after 2 and 4 months of hearing aid use in older adults. So, excuse me. So these changes may occur rapidly in 70-year-olds with bilateral sensorineural hearing loss. And again, I think this is very instructive of how good things could be. Does this guarantee that people wearing hearing aids are going to improve? Absolutely not. Absolutely not. This is a correlational study, and it showed really good correlation and really fast turnaround times. Doesn't mean it's going to happen with everybody. Nobody's saying it is. Certainly not causal. Nobody said it is. I'm going to leave it there. Journal of Geriatric Psych and Neurology, 2024. Initiation of hearing aid use and incident dementia among mid to late life adults. The Health and Retirement Study, 2010 through 2018, by these authors. 2,300 participants, 328 in the intervention group, 1,900 in the control group. 72 years of age, half male, half female, 81% white. During 8 years of follow-up with 14,000 a total of 14,728 persons. I hate when they do that, but 8 years of follow-up, 149 incident dementia cases occurred. So if we look at this, basically 72-year-olds, and you have 2,300, so you could anticipate 149. That would be, I'm going to guess about 7%, right, develop dementia. People with hearing aids, lower risk of incident dementia after 2, 4, 6, and 8 years. So the study went on, for this same period of time, right, for the 8 years or so. And what they found is lower risk of incident dementia in people who wore hearing aids. Implications. Hearing aids use was associated with a significant reduction of incident dementia. And when they say significant here, yes, that does mean statistically significant. This is Yeo Song To et al., Association of Hearing Aids and Cochlear Implants. So the reason I put this in, if you look through the literature, do patients with cochlear implants improve their cognitive ability? The answer is yes. It's been a very clear yes since before we started talking about this in depth with hearing aid interventions. And so I just put in one just to remind me to make that point while having this discussion. But yeah, cochlear implants do tend to improve cognitive abilities over time. So here's the study. This is 2023 in the Journal of the American Medical Association Neurology. Do hearing aids and cochlear implants decrease the risk of subsequent cognitive decline in adults with hearing loss? So they looked at 137,000 people. The use of hearing restorative devices, that could be a cochlear implant or hearing aid, gave you a 20% decrease in the hazards of long-term cognitive decline, such as incident dementia over a duration ranging from 2 to 25 years. So you don't get a cochlear implant and it instantly improves your cognitive ability or hearing aids, but it occurs slowly over time. And so it's important for us to be aware of that. Speech and noise hearing impairment is associated with increased risk of Parkinson's. Now, this is kind of new, right? This just came out in 2024, a year ago. A UK biobank analysis. So this is the same UK biobank that Stevenson et al. Were writing about with speech and noise. The present study observed that hearing impairment is a risk factor for incidence of Parkinson's, with the risk of Parkinson's incidence increasing 57% for every 10 dB increase in speech reception threshold. All right, this is admittedly a very, very challenging study to get your arms around. Excuse me. The congruence of the findings obtained here support the assumption that hearing impairment and Parkinson's are related through a common neurological cause. Well, remember we talked about the hypotheses as far as sensory deprivation causing cognitive decline. So these people are saying that hearing impairment and Parkinson's may have a common neurologic cause. And I think that's reasonable, although, I'd like to see this replicated. I read the study 2 or 3 times, and I would never say to a patient, ever, never, 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 that your hearing loss untreated might cause Parkinson's. No, this is kind of a new study, and it's kind of an important study, but I wouldn't share any of this with patients at this point because I haven't seen a lot of epidemiologic evidence showing this correlation. I've seen this study, and it's piqued my interest, but I don't know that I would ever share this with a patient unless I saw a lot more data on this. Krzyzanowski et al. Proximity to golf courses, same sort of deal. This study is not wrong, but it's easily taken out of context. Proximity to golf courses and the risk of Parkinson's disease. Published 2025, Journal of the American Medical Association Network, and it's an open network. Does living within proximity to a golf course affect the risk of Parkinson's disease? I know, but here's the thing. This case control study found the greatest risk of Parkinson's disease within 1 to 3 miles of a golf course, and that risk generally decreased as we got further from the golf course. The effect sizes were largest in water service areas with the golf course in a vulnerable groundwater region. So would I tell a patient who lives near a golf course, you're at a higher risk for Parkinson's? Absolutely 100% no. This study had to do with pesticides applied to golf courses get into the water supply, and they may play a role in the incidence of Parkinson's disease for nearby residents. So you could draw the conclusion that living near a golf course causes Parkinson's. That would be an incorrect conclusion from my way of thinking. This harkens back to a goofy statement I made years ago to prove the same point. You could say that drinking milk causes cancer. That would be a stupid thing to say. But then the argument, if you were trying to prove that in this regard, would be, well, virtually everybody who has cancer drank milk at one time. Well, that's just ridiculous. But you see, that's how people build arguments and do crazy things. Milk does not cause cancer, to my knowledge. I've never read anything saying that. But I'm trying to make the extreme crazy case where somebody might say, well, one of the things in common with people who have cancer is they all drink milk. Well, that's just a really silly thing to say. And it may be true, but it's crazy. And I wouldn't worry much about living by a golf course unless I was exposed to the same, water supply of the golf course. And it would have to be, the water supply with the insecticides in it and the fertilizers in it and all of that stuff. So they're making a good observation. It's a good warning, the pesticides are dangerous, and pesticides may be the precursor to some cases of Parkinson's. But, you got to take this stuff seriously and in context. And that's why they suggest pesticides. They're not really saying that it's the distance. That happens to be true, but it's not the primary thing here. I'm sure you all get this. So Internal Journal of Geriatric Psychiatry, 2024, 1 year ago. What explains the link between hearing and vision impairment and cognitive function? The association between hearing, vision, and episodic memory is mediated by allostatic load. That's the wear and tear on your body, social engagement, depression, and physical activity. Interventions to improve healthy lifestyle, reduce depression, and foster social engagement of older people with sensory impairments are likely to be beneficial in preventing cognitive decline and dementia. So now, we do know that social isolation is indicative of people who have hearing and listening problems. And we also know that just being socially isolated tends to be very bad for your brain because you're not building new neuronal pathways, you're not activating old memory centers, you're not engaging in conversation involving language and speech and memory centers and Wernicke's and Broca's areas of your brain and your temporal lobes, and you're sending less information across the anterior commissure and the corpus callosum. And you want to do this. You want to stimulate your brain as much as you can. And that gets again to the idea of cognitive reserve, which we mentioned earlier. The more we are adult long-term learners, and the more we stimulate our brains, the better it is for our brains. I don't know that it's as simple as brain games, and there are quite a few of them out there. People used to say 10 or 15 years ago, that just doing Sudoku, playing chess, and things like that are good for your brain. Well, they probably are. But, when I look at the peer reviewed literature on that stuff, it seems to be weak. I certainly want to encourage people to be in book clubs and to read and to do things that stimulate your brain. But I'm not sure that a simple game of Tetris is beneficial. I wouldn't say don't do it, but I think you have to be very engaged, and maybe Tetris can engage your brain that much. This is the argument that I remember making 25 years ago. I was saying that watching TV passively, watching a football game, that don't make you no sports person. That makes you an observer. And the thing that was so brilliant about Sesame Street and the Big Blue Marble is children would march around the room, chanting the ABCs and counting their numbers with Elmo and with Big Bird. And so they were engaged. When kids are watching Sesame Street, they're actively engaged in watching TV and learning and building brain. When you passively watch something, a movie, or just junk TV is on in the background or something, that's not really good for your brain, to my way of thinking, because you're not engaged in it, you're not learning anything, you're not thinking, you're just passively observing. So interventions to improve healthy lifestyle, reduce depression, foster social engagement are likely to be beneficial. This is untreated hearing loss, hearing aids, and cognition, a correlational outcomes. So I shared with you the 25 or 30 co-authors I had on this paper. And what I want to do now is work you through some of the citations within that paper. Dr. Wang et al. Reported 2,400 people, 1,285 were 80 plus years old. So that's substantial, right? We're looking at 1,285 80-year-old people. Moderate to severe hearing loss was associated with a higher prevalence of dementia compared to those with normal hearing. Again, this is kind of showing that same thing. As we said earlier, the at-risk people are older. So here they are 80 plus, and they have much more hearing loss. This is moderate to severe. This is not a bilateral, sensory neural precipitous ski slope sort of a loss. So having moderate to severe hearing loss was associated with a higher prevalence of dementia compared to those with normal hearing. And hearing aid use was associated with lower dementia prevalence. This is very much what Frank Lin said with the ACHIEVE study. If you haven't looked at the summary of the ACHIEVE study, this is all you need to do. See right here, www.achievestudy.org. Get that, go to that page. Because what they do there is they just give you a one-page summary. The ACHIEVE study in 2023 showed that in older people at risk for cognitive decline, hearing intervention slowed down the loss of thinking and memory abilities by 48% over 3 years. That's really all you need to know. It doesn't say everybody with hearing loss is going to benefit from hearing aids. Nobody said that. It doesn't say any such thing. So to give you a little color and a little background on the ACHIEVE study, right, there were primarily 1,000 people in the study, 4 locations over 3 years. Most of the people, it was a comparison of a healthy advisory group outcomes versus hearing aids. And they didn't see much difference in those healthy people, in those younger people, et cetera. But then they looked at the atherosclerosis group, the people who had comorbidities, in particular atherosclerosis. And that's what they're reporting on here. These are older folks with more significant hearing loss. These are people with comorbidities. And they found in that group, hearing intervention slowed down loss of thinking and loss of memory ability by 48% over 3 years by wearing hearing aids. So that's pretty good. That's, almost decreased by half in 3 years by wearing hearing aids. So get a copy of this. And I think it's so important that you have all these things at the ready. So when you're in discussions with patients, you could say, Mrs. Smith, I'm a little concerned about some of the things in your history and some of the things you've told me. I wanted to show you this study that came out a few years ago. And there's no guarantees, there's no promises, but I think it might be in your best health interest, given that you have moderately severe hearing loss, given that you're 82. I think you're going to just find life so much easier if we try amplification for 30 days. Let's see how you do. Because I think in 1 or 2 or 3 or 4 months, we should see you interacting a little bit more easily and things like that. Because you saw the study I showed you, 2 months, 4 months, big changes, right? And it's not a guarantee and it's not a promise. It's showing that there's a good possibility you can make somebody's life better and change the trajectory of their cognitive decline by having these discussions with appropriate patients in appropriate words, without any fear mongering or scare tactics, and just look out for the patient's best interest. Here's another, and again, these all are quoted and referenced in that paper that I shared with you. This is Cantoria's 5-year study published in 2024, 500,000 people. The author stated that hearing loss was associated with an increased risk of dementia. Severe hearing loss was associated with a higher risk of dementia. So this is exactly what I said earlier, that when people are in the at-risk categories, hearing loss tends to exacerbate their cognitive decline. That's what Cantoria is saying. Dementia risk was higher among people with hearing loss who were not using hearing aids, rather than those who were wearing hearing aids. And the authors suggested that hearing aids might prevent or delay the onset and progression of dementia in selected patients who are at an increased risk of dementia. Untreated hearing loss. So same paper, Dr. Yu et al. And again, you see this kind of formulaic approach, which I kind of like, as a scientist. I do like this because it gives me a risk assessment for the group, not for my patient in particular. But every 10 decibel worse hearing was associated with a 16% increase in dementia risk. And, this is 2024. So this I thought was particularly enlightening. And again, the full reference, if you want to read this, is in our paper that we published in 25, Untreated Hearing Loss, Hearing Aids and Cognition, Correlational Outcomes 2025. This is the Sarant study. So Julia Sarant is a PhD in New Zealand, brilliant researcher. Unfortunately, most people didn't hear about this study in the US. And the reason they didn't is because the timing was exactly parallel with the ACHIEVE study. Had it come out 2 or 3 years earlier, 2 or 3 years later, you'd all be quoting it, I'm sure. I did a interview with Dr. Sarant, and it was so enlightening. I really enjoyed speaking with her, and I learned a lot. So they did a 3-year study of 160 audiology clinic patients with mild to severe hearing loss, fitted with hearing aids at baseline, and they had 102 participant controls. The hearing aid users demonstrated significantly better cognitive performance as measured up to 3 years post-fitting, suggesting that hearing intervention may delay cognitive decline or dementia onset in older adults, not in 28-year-olds, older adults. So we've made all of these points many times, but I think it's important for you to see it's not one study, not 2, not 10, not 20, zillions of studies that have shown these same sort of things. And that's why I think it's so important for us to be aware of it. And, AAA and ASHA both say that cognitive screening, by the way, is within your scope of practice. And the reason they say that is because we do know that there is correlational evidence between hearing loss in at-risk people and exacerbation of cognitive decline. This is Dr. Yang and Lee et al. Again, we looked at another part of the study earlier today, but they concluded that hearing loss consistently increased the risk of all-cause dementia and Alzheimer's disease across time spans, suggesting a complex link between hearing loss and neurodegenerative diseases. Now, I will tell you that I often say, particularly when I lecture to physicians, that all hearing loss, I would say it more clearly. All hearing loss is neurodegenerative. None of it's benign and none of it is normal. And I think this is nice to see this here, a complex link between hearing loss and neurodegenerative disease. And I believe this to be true. And I think the evidence out of Harvard shows this to be true. And by the time we diagnose hearing loss at 8,000 hertz, we've already lost 20 down to 8,000 hertz. We've lost 12,000 hertz of hearing before it impacts enough of the audiogram for us to call it hearing loss. So this is something that I hope we will change in the very near future. I hope we'll start really really focusing on extended high frequency bandwidths, because I think they are so illuminating and they tell us way beforehand what's going to happen. You and I learned that hearing loss impacts the outer hair cells, and that's when it becomes a problem, right? And then when you get 50 or 60 dB of hearing loss, now it's going to impact the inner hair cells, and that'll cause more difficulties with distortion and with hearing clearly and all those things. Well, that's true. But long before outer hair cells and inner hair cells are damaged, the auditory neurons are damaged. And that is the whole idea of auditory neuropathy, is that we lose 20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9,000 hertz. Then when it hits 8,000, then it starts to hit the outer hair cells. So the first sign and symptoms of hearing loss is not outer hair cell damage at 8,000 hertz, but is auditory neuropathy from 20 down to 8,000 hertz. More or less my understanding of what I've read out of Harvard. So, and that's not new. I mean, they've been talking about this now for about 15 or 20 years. Another study, I'm not going to think of the name. Okay. In summary, there exists a correlation between untreated hearing loss in at-risk people and an increased risk of cognitive decline. Hearing aid amplification has been shown across multiple studies to reduce the risk of cognitive decline over the long term in many individuals. This is the laryngoscope association between hearing loss and dementia in a large electronic health record system. So this is, electronic medical records. And this was published in May of 2025, so just a few months ago. It was a cross-sectional study, multi-center, using electronic health records from Columbia University and Cornell. 32,000 people, 18 years old and older. They had clinical audiometry on these patients from February 1, 2020 through May 5, 23. Results. The mean age was 60 years, 40% male, 60% women, so fairly well balanced. I'd like to see studies on people in their 40s and 50s, because I am of the impression that by age 50, most people will have auditory neuropathy. I really believe that to be true, and that's based on what I've read out of Harvard. And I think we don't look for it, so we don't find it. You can't find what you don't look for, and you can't diagnose what you haven't tested for. But I think it's there, and I think we all thought of auditory neuropathy as far more complicated than it really is. With all due respect to our researchers who started entering auditory neuropathy into the audiology literature many years ago, we would talk about people with normal hearing who had no ABRs and things like that. And that became very difficult because all of us aren't going to test ABR. But I think there's other things we can do to find auditory neuropathy now in 2025, but that's a discussion for a different day. Anyway, so mean age 60 years, almost half male, half female. All univariable regressions show an increased odds of dementia with worsening hearing. That's a terrible sentence. But as hearing got worse, you had increased odds of dementia. And again, you're seeing this formulaic approach, but they did something really super interesting here. So for every 10 dB worse pure tone average, the odds of dementia increase by 1.11% over time. So it's an 11% increase of the odds of dementia for every 10 dB worse pure tone average. Now look at this. For every 10% worse word recognition score, the odds of dementia increase by 6%. For every 10 dB worse speech reception threshold, the odds of dementia increased by 10%. And they concluded, using a large electronic health record system, audiometric hearing loss defined in 3 separate ways, these 3 here, was associated with increased odds of dementia. Electronic health records can corroborate and expand previously studied relationships between hearing loss and its comorbidities, including dementia. So I haven't seen hardly any analysis of word recognition score or SRTs correlating with cognitive decline. But this is, kind of a first shot over the bow here. May 2025. So this is only 4 or 5 months ago. And I think it's going to open the way to other studies where probably people who've done pure tone averages and looked at hearing in its purest sense, without language, looked at hearing and cognitive correlations might go back and look at word recognition score and SRT. We do know from many studies that speech and noise correlates, over 10 years to a 61% increased risk of dementia. We've seen that in the biobank study from Stevenson based on 82,000 people. But this is saying, if you look for it in other areas, you might find it there too. So pretty interesting, opens up a lot of new doors for research. And I'll certainly be looking for this in the literature to see if other people corroborate this or whether this is just a one-off. They observed it, it's true for their study, but maybe it doesn't repeat. We'll see. I don't know. PAF, population attributable fraction of incident dementia associated with hearing loss, April 2025, in the Journal of the American Medical Association, Otolaryngology, Head and Neck Surgery. Eshok, Pike et al. Hearing loss treatment delays cognitive decline in high-risk older adults. Okay, that's it. That's the whole course. We don't need to go any further. But you have to understand that in medicine, they know about these relationships for decades. It's just, audiologists, sorry to say, who find it hard to discuss these things, even though AAA and ASHA said, yeah, you should watch out for this because, the reason cognitive screenings are part of our scope of practice is because you might need to do this because we know that the signs and symptoms of suprathreshold listening disorders, auditory processing disorders, central hearing loss, things like that, and cognitive decline overlap. In fact, they masquerade as each other. That's a term from Patty Krikos. She wrote that 20 years ago, that hearing loss and cognitive decline may masquerade or parade as each other. And here are the physicians in 2025, hearing loss treatment delays cognitive decline in high-risk older adults. JAMA, otolaryngology, head and neck surgery. This prospective cohort study was part of the atherosclerosis risk in communities neurocognitive study and had up to 8 years of follow-up. 3,000 people, 75 years of age, 1,900 of them had audiometric hearing loss, 1,097 self-reported. So that means, the patient said they had hearing loss, much like the Amoeba study, but there were no audiograms. The population attributable fraction of dementia from any audiometric hearing loss was 32%. So the PAF of dementia from any audiometric hearing loss was 32%. That's much higher than we've seen in the Lancet. The Lancet, as you recall, is about 8% PAF. This cohort study suggests treating hearing loss might delay dementia for a large number of older adults. Specific actions to reduce dementia. So, I don't want to end on all doom and gloom. If you're at risk, nothing you can do about that. But, then you might want to consider A, B, and C. There's a lot you can do. And in the Lancet 2024, they had a whole laundry list of things you can do to help prevent cognitive decline. And these are not causation, these are correlations. If you follow these guidelines, your risk of dementia goes down. It's not eradicated, it's not zero, but these are correlations, much like hearing loss. Ensure a good quality education is available. I think we're all aware of that. We've discussed that a lot, and that's the essence of cognitive reserve, is that the more we stimulate the brain, the better the brain will be. Make hearing aids accessible for people with hearing loss and decrease harmful noise exposure. Makes good sense. Treat depression effectively. Makes good sense. And if we can, in many people who have substantial hearing loss, they will be depressed. And if we treat their hearing loss early, there's a very good possibility that we may change the trajectory of their depression, delay it, or maybe avoid it. I'm not saying that you can do that. That would be causative. I'm saying there's a correlation between early treatments of hearing loss and having less anxiety and less depression and more social interaction. Encourage the use of helmets and head protection in contact sports and bicycles. I don't think we even need to discuss that anymore. I think that's just a given because there's high correlations between, head injury and cognitive issues. Encourage exercise. Well, of course, reduce cigarette smoking, reduce or prevent hypertension, maintain systolic blood pressure of 130 millimeters or less. And, that's something that's been changing over time. I remember when 140 over 70, was high, but 130 over 75 was considered okay. And now I believe it's 120 is the upper limit. And, it keeps going down, which is great because if you can maintain a lower blood pressure, you're at lower risk for stroke and for heart attack and other cardiovascular disease. Detect and treat high LDL cholesterol from midlife. I think that's good. But the definition again of high LDL or HDL changes. So you have to be aware of the latest changes. You can find that at JAMA. Maintain a healthy weight and treat obesity as early as possible, which helps to prevent diabetes. Absolutely. I wrote a paper on diabetes this year, and I'll tell you the numbers, which are kind of shocking. In the USA in 2025, there's about 40 million people who have diabetes, but pre-diabetes is about 100 million. So almost 1 in 3 Americans has diabetes or has pre-diabetes. And when you have diabetes, your risk of hearing loss goes up times 2. When you're pre-diabetes, your risk of hearing loss goes up 1.3 or roughly 30%. Reduce high alcohol consumption through price control and increased awareness of levels of risk of overconsumption. I'm not sure what that means through price control. Make beer like super expensive. I don't know if that's going to work. Prioritize age-friendly and supportive community environments. That is, get people involved. Don't live in social isolation. Reduce social isolation. Make screening and treatment for vision loss available for all. But I will tell you that most of the optometrists I work with a few dozen of them, they have the same feeling about vision screening as I do about hearing screening. It's usually not worth doing. Every single patient deserves a comprehensive audiometric evaluation. Is that expensive? Yes, it is. Does it take time? Yes, it does. But people go see their OBGYN, they go see their dentist, they go see their neurologist, they go see their family doctor, they go see their neurologist because it's worth it. And I can't do much about the price of healthcare. I can't, and I can't reduce the wait times. There's only 12,000 or so, maybe 10,000 neurologists in America. There's only about 12,000 otolaryngologists. There's only 12,000 audiologists. Yes, it takes time, but none of those other professions do screenings. OBGYN does not do screenings. Dentists certainly don't do screenings. Optometrists, they don't really do screenings. Your GP doesn't do screenings. You make an appointment, you come and see them, you pay for that, and you get an accurate diagnosis and a treatment plan. And that's what I urge in audiology. Hearing screenings, to me, as I've said many times, not worth the time or effort. Only 20% of people who have a positive screening, meaning they failed their hearing screening, take it seriously. 80% never do anything about it. Reduce exposure to air pollution. There you go. So there's a lot you can do, right? FDA news release. This is the one I told you about earlier, that the first blood test from a simple blood draw, which can be used to diagnose Alzheimer's, and is looking at the ratio between tau and amyloid. And this is amazing. Alzheimer's disease impacts too many people, more than breast cancer and prostate cancer combined. 92% of people with a positive Luma pulse had amyloid plaques confirmed by PET scan, that's positive emitting, and CSF, that's cerebrospinal fluid. 97% of individuals with negative results didn't have it. So, and 20% of people who get this, the result is indeterminate. But if it says it's positive 92% of the time. If it says negative, it's correct 97% of the time. If it says it doesn't know, it doesn't know. But this is very impressive for people who are at risk for Alzheimer's disease and concerned about it, because it's not just a learned physician's opinion as to whether, we're going to give you a diagnosis of Alzheimer's. It's a blood test, which is pretty much proof positive. These are amazing numbers. The FDA indicates the new test is for patients presenting at specialized care settings with signs and symptoms of cognitive decline, and the results must be interpreted in conjunction with other patient clinical information. In other words, it has to be interpreted within context. This is Pike et al. This is the Achieve Collaboration Research Group, May of 2025. Hearing intervention. Let me just move this out of my way. Achieve trial suggests hearing intervention may not reduce 3-year cognitive decline in all older adults, but may be beneficial in certain groups, like those at risk. The secondary analysis investigated if people with multiple risk factors received greater benefits. The answer was yes. From among Achieve participants in the top quartile of predicted risk, 3-year cognitive decline in hearing intervention was 61% slower than the control group. Again, making the same point we've made a couple of times, that people who are at risk benefit the most from hearing intervention with regard to their cognitive decline trajectory. The effect of hearing intervention on reducing 3-year cognitive decline was greatest among people with multiple baseline risk factors associated with faster cognitive decline. Association between cochlear implants and dementia. I showed you this one. Well, I showed you a similar one earlier. Longitudinal study investigated whether restoring hearing through a cochlear implant influences cognitive decline and the risk of dementia. Developed 2010-2020, 356,000 patients, 50 years and older. 2,400 of them had cochlear implants. Among the implant recipients, 11% were newly diagnosed with dementia, compared with 17% of non-recipients. That difference was statistically significant, indicating that people who got cochlear implants appropriately had a lower risk of dementia than people who did not. Cochlear implants are beneficial in preventing dementia, even in patients older than 70 years, was the conclusion. 2025 Lancet, almost 60% of dementia cases in Brazil could potentially be prevented by addressing the 14 potentially modifiable risk factors, which we shared earlier today. Public health strategies could further reduce the dementia burden in Brazil. I think that's true. Hearing loss as a risk factor, May 2025. We've looked at the reason I put this in is that a lot of people are concerned that maybe the stuff that we're talking about here is essentially a Western world phenomena, true in North America or perhaps in Europe. These this study looked at multiple locations across the globe, and the findings indicate that the association between hearing loss and incidence of dementia is consistent globally. The Framingham Heart Study suggests people under age 70 with hearing loss who use hearing aids may significantly reduce the risk of developing dementia over the following decades. This came out in 2025. This particular version of this was written by my dear friend Carl Strom, and you can get this at Hearing Tracker. Hearing Tracker, 61% lower risk of incident dementia among younger people with hearing loss who reported wearing hearing aids compared to people who did not. Early diagnosis and treatment of hearing loss may play an important role in brain health and underscores the importance of not delaying intervention. Because if you avoid these landmines to begin with by treating hearing loss earlier, then you don't have to deal with the worst outcomes associated with developing anxiety, depression, social isolation, maybe cognitive decline, all those things. If you intervene early, don't wait until the 70s and 80s, intervene as soon as we realize there's a problem. Self-reported hearing aid use and risk of incident dementia, also from 2025. Age-related hearing loss is a known risk factor for developing dementia. There you go. That's in JAMA. Age-related hearing, and if an audiologist or dispenser were to say that, they would be questioned. Framingham Heart Study, original and offspring cohorts, 2,900 participants, 69 years of age, followed up for 2 years. 20% developed incident dementia. People with hearing loss with hearing aids, reduced risk of dementia among those younger than 70 at the time of hearing aid evaluation, compared with participants with hearing loss without hearing aids, had a 61% lower risk for incident all-cause dementia. So kind of interesting, right? So none of this is particularly shocking because we've been talking about this for 15 or 20 years now. And, I could just go on and on with all these studies, but hearing disorder onset was associated with an increased dementia risk. Here's another one. This is also 2025. We talked about this one earlier, so sorry about that. And this one, August 2025, emerging evidence suggests pure tone hearing thresholds relate to cognitive decline. Every 10 dB increase in hearing loss, 16% increase in dementia risk. And these are for people who are at risk for dementia, based on the criteria I've shared with you 4 or 5 times today. This is online in 2025. Adults with hearing loss who began using hearing aids before age 70 had a markedly lower risk of developing dementia compared with those who did not use them, according to findings published in JAMA Neurology. And again, you can easily Google this. The analysis showed hearing aid users 60 to 69 years of age had a 61% lower risk of incident dementia up to 20 years of follow-up than people who did not use hearing aids. Dual sensory integration. This one, the only thing I'm going to say about this, because I kind of covered this earlier when I showed you the paper that is being released in 10 days. New research reveals how the brain merges visual and auditory information to make quicker, more accurate decisions. And again, most of this is covered in my new paper, which you'll get soon. And in the ASHA November, December, I talk about hearing screenings, an incomplete peek at a complex problem. I just want to remind you that's coming out in a few weeks. You can get a copy of that. Here's what I say. Audiology does and should consider the whole person, not just their hearing loss. We should focus on individuals, not groups. Many factors overlap, masquerade, and impact audiometric evaluations, including psychological well-being, depression, anxiety, cognitive ability, auditory processing, central hearing loss, subclinical hearing loss, auditory neuropathy, cochlear synaptopathy, communication and listening problems, speech and noise ability, and more, the majority of which are not recognized, assessed, diagnosed, treated, or referred via hearing screenings. So my beliefs. Hearing loss. Does hearing loss cause cognitive decline? No. Untreated hearing loss in at-risk people often tends to exacerbate cognitive decline. I've been saying that exact same thing for 10 years. In some articles, amplification has been shown to reduce the risk of cognitive decline over the long term. It's not just hearing loss, it's sensory input to the brain, vision, cochlear implants, etc. We should test, treat, inform, and treat patients professionally. We should never use scare tactics for any reason. Scare tactics are deplorable and unethical. We should embrace our role and our responsibilities as doctors, clinicians, licensed professionals, compassionate human beings, and we should practice to the top of our license. We should embrace nationally recognized scope of practice, best practice, and contemporary peer-reviewed science. Hearing screenings for these purposes are usually a waste of time and resources. That's my opinion. Mark Twain says, whenever you find yourself on the side of the majority, it's time to pause and reflect. I have 2 mentors in my professional life, Dr. Jack Katz and Dr. Bill House, both of whom have passed, unfortunately. But I remember working closely with Bill House as well. And Bill used to say, it's tough to be a leader on the wild Western frontier because the leaders and the scouts, they're out in front and they're the ones who get the arrows. And Dr. Bill Hitzelberger, who did a lot of work with House, I think Hitzelberger took out more brain tumors than any other neurosurgeon in the history of the world. And he said, when you offer new clinical ideas, some colleagues say, well, it's dumb. It's never going to work. It's not right. We tried it. It doesn't work. And then after you succeed, they say, yeah, I told him it was a good idea. I thought of it first, actually, and it was obvious. Everybody already knew this. And so I want to thank Alan Seni in particular and all of you for sitting through this and for allowing me to ramble on for 2 hours. I'm not going to be able to speak for the next week, but that's probably a blessing. And I'm happy. Let me take a look in the chat. Yes, I agree with Kathy Senni, 100%. Let's see, Q&A. Okay, we're at the Q&A. When you talk about auditory neuropathy, are you also referring to central auditory processing? No, I am not. Auditory neuropathy is basically the degradation of the outer fibers of the auditory nerve. They disappear over time. And as you know, they're tonotopically oriented and topographically oriented. So the outermost fibers of the auditory nerves are the highest frequencies. Central auditory processing has more to do, and this is Jack Katz's definition, auditory processing disorders are what you do with what you hear. So it's how your brain takes what you hear and makes it into something that makes sense to you. It's how you interpret auditory information. Not a question, but Dr. Harvey Abrams told me to please give Doug my warm regards. Thank you, and send Harvey my love. Could you please review the criteria for people who are at risk? Yes. At risk means you have greater hearing loss, you're older, you have multiple comorbidities such as cardiovascular disease, diabetes, atherosclerosis, etc. You probably have polypharmacy, meaning more than 5 drugs. You have lower formal education, and you're probably in the lower socioeconomic groups. And the more of those you have, the higher your risk of cognitive decline. Those are the criteria for people who are at risk, and you can read those in the Achieve study. Go to achievestudy.org. Nicholas, you indicated that outer hair cells don't die until 8,000 hertz. Well, no, that's not true. If I said that, I spoke incorrectly. We don't notice it until 8,000 hertz is what I meant to say. Do you believe that extended high frequency outer hair cells don't die until play a part? No, they do. Of course, you insisted was solely, I insisted. I rarely insist, but if I insisted, then that was an error. What I meant was we don't really talk about it or notice it or flag it or diagnose it until 8,000 hertz. Not to say it doesn't happen. Of course, it happens from 20,000 down to 8,000. So thank you for allowing me to correct that. Let's see. Do we have any? Do we have any other questions? I'm happy to take more if there are any. Here's something that just popped up. I'm a 4th-year audiology extern and also a hearing instrument specialist. Your presentation is very informative and insightful. Thank you, Sonia. I appreciate your kind notes, and I wish you good luck in your career. And that's a wonderful thing to be an audiology extern and an HIS. I think your experience will benefit many patients. Versus Sudoku games reading aloud. This is not, I'm probably missing part of this. All I see is something versus Sudoku, crossword puzzle again. Reading aloud in quiet and in noise speaks about this. Yeah, it does. And again, I think the more you engage your brain, the better off you are. I just think we don't have, peer-reviewed studies on Sudoku or crossword puzzles or stuff like that. I would encourage it among people who like it. And the whole brain games thing, it used to be like Lumosity and stuff like that. But the peer-reviewed outcomes on it hasn't been that impressive. I mean, they're good. Some people certainly benefit from it, but it's not a wholesale management technique for avoiding dementia. I think you have to do multiple things and do them all intently, and do them all with vigor and really be involved. You have to get your brain training on multiple things, and the more integration you have of audition and vision and cognition, the better. Happy to see if there are any more here. I got 6 minutes left. All right, Olivia, how did we do? What did you think about this? And I think it's important that we update this every year or two, because most of what I showed you has come out in the last 24 months. Most of it is supporting many of the premises that many of us made. I mean, I go back to some of the papers I wrote 7, 8, 9 years ago on should we be doing cognitive screening? And we said yes, and we said, here's why. And we did, listening is where hearing meets brain. Again, Carol Flexer and me did that one 15 years ago. And I think as we gather more and more evidence, it helps to support the basic premise of the correlation between hearing loss and cognitive decline in at-risk people over time. Reading aloud better than games. Yes, thank you. Whoever wrote that just clarified that, and I would agree. that that's true. Because when you're reading aloud, of course, you're hearing, you're listening, and you're speaking. You're involving Wernicke's and Broca's parts of your brain. You're engaging your speech mechanisms. You're engaging your larynx. You're in great, which is your 10th cranial nerve, and your 7th nerve, your facial expressions, and your 8th. So you're engaging more of the brain at any one time when you speak and read aloud, and particularly if you're reading very intelligent work, not comic books, although comic books can be very engaging as well. All right, well, I think we're at about the end of our session here. I cannot believe that my voice held out for 2 hours after speaking for 90 minutes last night. So I'm going to celebrate by having a bourbon this evening. And thank you guys. It's such an honor to, I don't know, Alan's been doing this for whatever he said, 18 years or something. And I think I've been doing it twice as long with Alan. Just we did it off screen. So thank you very much. Excellent presentation as always. Thank you, Sam. I appreciate that. You guys have a very safe weekend. I wish you nothing but joy and happiness. And I'm so glad that we had this opportunity to be together. And I am going to end it now and turn it back over to Dr. Sene. And I hope to see you all again next year.